So anyway, if you ask people to do stuff, they often will say yes. So I call
Yeah,
so he can see us.
like a little
How are you? There you are.
Doing very well.
Look at that. Excellent. I'm going to turn this around in just a second so you don't have to look at me anymore because you look at all these beautiful students.
The bigger than life picture of me behind you.
Yes. Can you see it? It's like one of those infinite regress things, like looking in the mirror. So
Yeah, right. You keep seeing it over and over.
Exactly. So welcome. Anyway, I just thought it was really interesting because we've been sort of talking about Ebola the whole quarter because it's the thing in the news, and then you popped up into the radar screen, and it's just be really great to hear your impressions. Yes. So first of all, why don't you tell us a little bit about what your background is in terms of what your job is here and how you ended up going to West Africa and what you did in West Africa. So that would be a good place to start.
Because Stanford is big on formal titles. I'm a clinical assistant professor of surgery in the Division of Emergency Medicine, and I am the Mark Andreessen and Laura Arriaga Andreessen Medical Director for Disaster Preparedness. And I'm required to say all of those words together. I'm sure that's part of the title. So that means part of the time I'm a grunt pit doctor who works shifts in the emergency department, and another large component of my work is hospital disaster preparedness. When I'm not doing those things, I'm an urban search and rescue doctor for FEMA, California Task Force 3, and I help organize a group of volunteers under the auspices of something that we call SEMPER, the Stanford Emergency Medicine Program for Emergency Response. There's all this background, curriculum vitae, resume kind of stuff that's brought me to this point, and if you're all interested in that, I'm happy to tell you the long story. School teacher, firefighter, landscaper, bicycle messenger kind of stuff, which is actually kind of interesting, but I think we want to talk about a virus today. So I've been doing hospital-based disaster preparedness and humanitarian disaster response work for a number of years now. And most of the responses outside of the hospital have been with a group called International Medical Corps. They're smaller than Doctors Without Borders. They don't have as large a public profile, but pretty much any place that MSF is, you'll see International Medical Corps too, kind of quietly working side by side in the same locations. So my first work with them was in Haiti, immediately following the earthquake. I helped administer an intensive care unit and an emergency department at the hospital, affectionately called the General, the main teaching hospital in Port-au-Prince. And I've subsequently done a lot of other work with International Medical Corps. When we started to see the news of the outbreak in West Africa, coming out of Guinea and Sierra Leone and Liberia very early on, I expected to get a call. And so I kind of, towards the end of August, started clearing my schedule. And I was told by International Medical Corps, yeah, you're going to go out on September 1st. We don't know if we're sending you to Sierra Leone. We don't know if we're sending you to Liberia. And so I cleared my clinical work for the month of September. And then the logistics finally came into place on September 21st. And so then I had people waiting on me, and I just said, look, and as soon as I get the word, then I'll call and say, okay, clear the rest of my schedule off. But I don't want to keep putting people on hold because it's an effort for all the other people in the hospital that have to support me when I'm away. So September 21st, I flew to Monrovia, essentially getting there late the night of the 22nd, and then drove to Bong County, which is one of the early centers of the outbreak, and what happened there. It is a fascinating story. It's been written about and published in the New York Times, but I can quickly go through that. And one of the 6 original ETUs, and that stands for Ebola Treatment Units, and I think the first or second rural ETU was there, and IMC had just started working at that point. And that technically opened and took its first patient on September 15th. The story behind Bong County was there is a hospital, it's called Phoebe Hospital, Phebe, if you want to try to Google that. Phoebe Hospital got an early case. Somebody came in with diarrhea, probably looked more like typhoid or malaria, and this is not when Ebola was on everybody's radar. And very rapidly after, and nurses, doctors took care of this patient, a lot of cleaning up, just general nursing care because of the diarrhea, and 6 clinicians immediately got sick and died. And when this was recognized as Ebola, it shut down the whole hospital. So the downstream implications of that obviously are that then this area where there's an outbreak and other people are getting infected has no health care. Their main receiving hospital is down. Also, normal blood pressure, diabetes, acute appendicitis, none of that stuff is getting treated either. Initially, the management of the ETU was going to be run by the local hospital staff, but then was handed over to IMC kind of at the last minute, or very late in the development. And IMC came in and took that over. There's some smoothing of the waters for that needed to occur afterwards with the hospital. But I think that at the end of the day, that was probably the right decision because that helped Phoebe Hospital come back up online to say, International Medical Corps is going to run this Ebola treatment unit. You guys focus on getting your other hospital activities up and running. And you won't have to, and you can securely operate without having to be concerned that you're going to also have to be treating Ebola within your facilities. So then I worked for doing direct treatment for just over 4 weeks, and some administrative functions, and also an assessment of another Ebola treatment unit. And then flew out very early in the morning of October 23rd. Arrived back here, had a massive adventure in New York City that sometime later going to a book, and have been on a quarantine. And in the press, this says I put myself in voluntary isolation, but I could go and hold up the 2 sheets of paper that say, if I violate this county public health order, I will be jailed for 6 months, and they have told me that that is, in fact, what they will do. So a component of this is not at all voluntary. We would have made International Medical Corps, Stanford Hospital, and I, as a responsible clinician, would have made all safe isolation precautions. We would have put those in place to make sure that I didn't share any potential infection with my family, the hospital, my neighbors. That, I can say with fairly high degree of certainty, would have been in place without a quarantine order. But there's a lot of politics that come behind that. So what would be most interesting to talk about now is that the mechanics of treatment, some of the social implications, downstream implications for a viral epidemic, is it quarantine issues or hospital preparedness? What topics are at the top of your guys' mind right now?
I was going to ask a quick question. Sorry, I'm over here a little off of your field of view.
That's about all right.
I was going to ask just about some logistics about your quarantine. Like, how long have you been there for, and how much longer do you expect to stay isolated? And what kind of what kind of symptoms would you be waiting for to be like, gee, maybe I actually had Ebola after all?
Yeah. So starting with the last part of the question first, the symptoms that we monitor for, and part of the quarantine is twice-a-day calls from public health, and they'd like to start Skyping this so that they can physically look at me versus having home visits, but they were nervous to conduct the home visits. I think the first one's going to occur this afternoon. We use a case definition of the most common symptoms, and I've kind of influenced that a little bit because I can say, look, guys, some of those symptoms you're asking are really late-stage symptoms, and here's the ones that are common in the early stages. we review this, and I think it's useful for someone else to ask me this to make sure nothing's falling off my radar screen. But then we also check temperature. So twice a day I check my temperature. And we do this call in, and we use the case definition symptoms, which are, if I can remember right off the top of my head, fever, generalized sense of weakness, loss of appetite, nausea, vomiting, diarrhea, rash, change in color of the eyes, redness or yellowing of the eyes, I forgot, diarrhea, bleeding of any kind, a rash, joint pain, muscle aches. And they're kind of forgetting sore throat or throat pain here, which is very common but is not written about much. They sometimes remember to ask me about hiccups, which are interesting in Ebola because they're a late stage and very ominous sign. Bleeding and hiccups are terrible things to get if you have Ebola. They mean the writing is on the wall and that there's likely no survival. And I just watch myself. The quarantine started the night of the 23rd when I arrived back and is officially lifted at 12:01 a.m. on November 14th. My wife and dog are staying in a hotel, and they will move back in just after midnight on the 14th. The mechanics have not been that difficult. Technically, I'm allowed to go for runs or walks or bikes in the neighborhood. It's solitary exercise is what's allowed. But because of the scrutiny that other folks have gotten when they've pursued that, I've decided to just exercise in the house. I haven't been doing much biking or running. In less than, 3 times I've been outside of the house for exercise. And not because it wouldn't be safe, it would be utterly safe, but just to reduce the amount of scrutiny. I can't be within 3 feet of a person, so that means I can go on onto the porch and get the mail, pick the newspaper up off of the driveway, wave to the neighbors, these kind of things. Have food delivered, and that's not been difficult. So I can order a pizza, I can go online and have groceries delivered, and I've been able to participate in a lot of work-related activities just through teleconferencing. That's kind of the mechanics of being in a quarantine right now. I think that I should. It would be utterly safe if I got in my car and went to Half Moon Bay and sat on the beach. But they've written my address down as the location for my quarantine on the paper, so I don't want to test that at all. It's certainly no different being in a car or being out in the middle of a soccer field in terms of risk to the public, unless I'm terribly incontinent with diarrhea.
So I have a question. I have a million questions, but I don't want to dominate this too much. But this is something that we've been talking about. So you sort of gone to extraordinary efforts to help control the outbreak, and I've kind of emphasized the importance of controlling the outbreak in West Africa. So we can assume that you have no desire to infect anybody and perpetuate the epidemic. How realistic are these quarantines? Do you think you actually pose any risk? Have you seen anybody who, during the incubation period, in West Africa, we know it hasn't happened in the U.S., but in West Africa, has anybody in the incubation period transmitted the disease?
Yeah, you mean without symptoms?
Yes.
I really don't think so. The classic description of this as being transmitted by body fluid with an increasing likelihood with volume of fluid and degree of symptoms. So we would get households where you would say, who is the primary caregiver? And who is really cleaning up after the sick person? And that person would get sick. But not everybody in the household would get sick. And this really said close contact with highly symptomatic people is the way this was transmitted. We all sit on the edge of our seats because the veracity of these histories is limited. Like most people don't live their life saying, well, at 12:23, I remember I cleaned the diaper of this newborn child. And then the next day at 11:17, I start to feel achy. So, there's people will say, well, maybe I had contact with so-and-so last week, but I also went to a funeral 3 days later. So when we get these histories from people, there's some of the accuracy is always suspect. But the main history was, yep, I was taking care of somebody who was really sick, and that's how I came into contact with this, and that's why I just don't get bent out of shape about this. If people are socially isolated and they respond quickly to early symptoms, I think that this is that the transmission is very readily managed.
Do you think that the current policy with regard to quarantine will have any impact on whether people volunteer to go to West Africa?
Absolutely. We've already felt that. It is much harder to recruit Americans to do this work. You've got an already scary disease requiring an extended deployment, which is tough to put together, and then you've kind of stigmatized the return process, and every caregiver has to navigate kind of Byzantine set of regulations. They don't know because the CDC makes recommendations, the state public health office makes recommendations, and then it's really the county it's a county by county basis to implement these, and the counties can be more stringent than the states. And so I know a provider someplace else in California that I worked with who's just gliding right through this and has far less restrictions on his movements than I do right now. And figuring that out in advance is a challenge. And so I do that, and when I've been interviewing candidates, I've been interviewing more candidates from outside of the U.S. than inside the U.S.
And what impact is that going to have on turning the tide of the epidemic in West Africa?
Yeah, so if the real answer to this is hit at the heart of the beast and control this there, and that's what my gut and any rationale can tell me is the most efficient way to control this is to get healthcare workers there, whether it's nurses, doctors, epidemiologists, it can be social workers with a bit of health background for contact tracing, but it's really essential. And can I quantify? Can I say, oh, we're going to get a 30% decrease in volunteers? No, I would be making up numbers, but we do see that it's having a negative impact. And actually, one of my interviews was misinterpreted by a number of future potential volunteers who said, well, he's really cooperating with this, and he's taking all these measures to isolate himself is voluntarily, because the interview kept saying voluntary isolation and voluntary quarantine, which were not my words at all. Those were...
Okay, we missed that last bit.
So some of my messaging to say we're using an abundance of caution to make sure the community is safe. I followed all the rules, but there's a 21-day incubation period, was interpreted as by potential volunteers as that doctor followed all the rules, but he's really scared he could infect somebody. Why is he so scared? And that was the wrong message, and that was not what I wanted to convey at all. And so I feel slightly, I was surprised by that interpretation, but I felt badly about it. It needed some correction.
There's another bit of messaging I want to ask about, and the messaging is that you're equally at risk of developing disease on day 1 of your quarantine and day 21 of your quarantine, and that clearly is not the case. And so, but everybody's being treated as if you suddenly on day 21 you went from furiously contagious until, seriously at risk of developing disease to nothing. What does the curve actually look like? Is this a bell curve? Is this, you know?
No, I think it's I think it's steeper earlier on, and then tapers out very gradually towards the end with a very thin taper at the end stages. So I was very happy to make it to 7 days, but we also saw a lot of people who seemed to be symptomatic with contact that was 9 to 10 days prior. And so after I got 10 days out, I was very, very happy. And now that I'm into my single digits for how many more days of social isolation quarantine that I have, I feel much more confident that if I developed a fever, it would be a common cold, another flu-like virus, or malaria, which I was also very diligent to prophylax against, than it would be Ebola. At this stage, I'm feeling I'm feeling much more reassured that slight possibility of me developing Ebola is even lower now.
Dr. Butts, if you were to write a quarantine policy yourself, what would you make it be?
So let's say, what was the plan before I was put into quarantine? And my provisions needed to incorporate my wife, who is also a physician with a clinical practice. So I needed to be separated from my wife by 3 feet, okay? And with no contact to bodily fluids, meaning no errant, like I have to pee straight when I go to the bathroom, for lack of a better term, right? So there needed to be separation from my wife so that she could, the downstream effect is if I develop a fever, then she would go into quarantine also and her patients would suffer. So we recognize that would be, there need a degree of social isolation from each other for that reason. But otherwise, would I remain in my house? No. Would I feel comfortable going to a grocery store and and feeling the ripeness of tomatoes? Yes, absolutely. But would we have made provisions that if the instant I developed a fever or any symptoms, would I have safely transported to a hospital that could treat me and I would alert them in advance? Absolutely. I think that monitoring by public health is absolutely effective and useful, and having the public health call and check twice a day and record a temperature trend is very effective, and I would have been happy to coordinate that. So it would have been social isolation, but it wouldn't have been strict quarantine. Would I have felt comfortable going to a movie? Yep. Would I have probably kept 3 feet distance between other people in the movie theater? Yeah, and it might not be necessary. The public health said it was certainly safe for me to sit on an airplane, and I was not flying first class. And we weren't concerned, without symptoms, without a fever, that I was transmitting anything different than anybody else on that airplane, if you will. If I had sneezed on that airplane, I could have transmitted coronavirus or rhinovirus, just as the person sitting beside me could have.
So we talked about several misconceptions that don't go, of policy that don't go along with what data we know. Did we miss any? What other misconceptions do you think are not aligned with the data?
I was told that if I drive my car to the hospital, should I get a fever, it would be towed and burned. That, I think that as soon as it was announced that I was in San Mateo County, a friend of a friend's Facebook page, it was 3 steps removed, said immediately, well, if I lived in San Mateo County, I definitely would only be going to work and going back to my apartment because there's a doctor with Ebola running through the neighborhoods. And that's not public policy, that's public interpretation of things. And so, and herein lies a lot of the challenge. as careful as you are, people are still dumb and interpret it in a lot of different ways. And a lot of what I've tried to do is try to quell those fears and add some reason into that. But if you do anything that's beyond the science, it's also can be publicly misinterpreted and confused. If that makes sense. We say, well, if it's not necessary, if you could be out in public, then why are you staying in your house? Good question. If this was up to me, I would go to the grocery store. I would go to the hardware store. Yeah.
Dr. Butts, could you talk about the treatment process? Like, do you treat, did you treat people who were in the beginning, early stages of Ebola the same way you did people at the later stages?
Yeah, great question. And I've been spending a lot of time since I've been back working with practitioners in the U.S., certainly Stanford and Lucille Packard Children's, but then also the hospital system up in Washington, EMS providers around the state, Scripps healthcare system, talking about what did we do there, which I'll answer, and then how would this be adapted here in the U.S., where you've got more testing available to you and you have potentially more treatment modalities available. So yes, a patient arrives at Ebola treatment unit. They walk up, they're sent by an ambulance, they arrive in a taxi. Any of these routes are possible. And we ran an ambulance service, an Ebola treatment transport service that was going out and identifying patients and bringing them in. So the first thing that happens is you screen them with the case definition. Fever, yes or no. Contact, yes or no. And then what symptoms do you have? And if they had a good story for contact and they had fever, then essentially they just needed one symptom and we said, yep, you're in. If there was no fever but a contact, but they had 3 or more symptoms, then they got admitted to rule out. If there was no strong contact history, no fever, no symptoms, they go home and we would give them a thermometer. We'd give them a patient education packet to say, here's how you continue to monitor yourself. If you develop these things, if you meet the case definition, this is what we want you to do. And take your temperature twice a day. And then education for preventive education. So if someone met the case definition, we brought them in. If they had contact, no fever, no symptoms, they were discharged. I mean, they were sent home with the education. And as soon as they were admitted, we drew a blood specimen to test for Ebola, and we started treatment. And the treatment was fluid resuscitation, either with oral rehydration solution, if they could drink and take fluids without vomiting, or if they're strong enough to drink, or place an IV, give IV fluids. Everybody straight out of the bat got treated for malaria because it was endemic and it was so similar to some of the symptoms were so similar. Everybody got straight out of the bat got broad spectrum antibiotic, not because we think that antibiotics do anything for viruses. No, we spend our lives educating on that topic. But the concern for co-infection, or potentially that this could be typhoid, and like a bad kidney infection can also look very much like early Ebola. Not uncommon for people to have a urinary tract infection that goes up to the kidney. And so hence the antibiotics. I said as a clinician, I would take my history and do a physical exam, and I might have 6 different things in my mind that this patient could potentially have, but I was a one-trick pony in terms of how many tests I had. We technically had malaria tests, but we rarely used them since we were treating anyway. When I first got there, it took us about 4 days to get any broad-spectrum antibiotics, medication for fever and pain, multivitamins, zinc if you're having diarrhea, and medicine to control vomiting, and some things for anxiety, plus minus. Some people would get encephalopathic, which is a confused, delirious state, and then they might need some antipsychotics to help them help address the delirious state. Mainly just put them to sleep. But everybody was getting volume resuscitated. And one of the debates in Ebola treatment is how much IV fluids. IV fluids are labor intensive to administer, and so if you have lots and lots of patients and you're dedicating that effort to giving IV fluids, then there's the potential that other people won't get other treatments. And so that's a cost-benefit analysis that you have in terms of rationing amount of care. I think in the US we would not face those challenges, and we also have more immediate testing. Now, I could get an Ebola test result back. Initially it took 4 days when the test had to go back to Monrovia to get done. They said 2 days, but it really wasn't. It was happening in 4 days. And then the US Navy set up a lab about 10-15 minutes up the road, and then we could get the test back in between 4 and 5 hours, depending on the time of the day, if we got the test there before 4 p.m. And that was phenomenal. So I could get a test back within 4 days, within 4 hours, 5 hours, have a patient that came in the morning and be able to say in the afternoon, we don't think it's Ebola. We didn't hang our hats on that in the early stages of the illness. Because just like Rory is saying, I don't think you can transmit this illness if you're not heavily symptomatic, if you're not symptomatic. We also know that we are getting false negatives in the first 72 hours because the amount of virus in the blood was too low to measure. So we needed somebody to be symptomatic for 72 hours. We needed them to have symptoms for 72 hours with negative Ebola tests during that time before we could confidently say you can leave. If we got you at 48 hours and your test was negative, but you were symptomatic, we still needed to watch you for longer to say, no, we really think this is not Ebola, this is something else. Does that make sense?
Given that every hospital in the Bay Area should be equipped to deal with respiratory syncytial virus, influenza, SARS, multiply drug-resistant TB, how much additional effort should be put into protection against Ebola, which I know right now people are being hired full-time at UCSF and Stanford for that purpose?
Yeah. We're wading into a quagmire here. And
I love quagmires.
And I can be a little philosophical about this and optimistic. From my disaster preparedness perspective, emerging infectious disease preparedness has lagged in the country for decades. And so now we're getting this big shot in the arm, just like in post 9/11, so much resources got poured into terrorism, and every small hamlet in the country got bomb-sniffing dogs and very elaborate hazmat. If at the end of the day, I tell you, I think that this is really good, that we're doing more to make ourselves, it's going to trail out over time and make us more prepared hospitals. The challenges with Ebola, specifically in the clinical management, are that when you get to the symptomatic stages, what we refer to as the wet stages of the illness, with diarrhea, with lots of diarrhea, with lots of vomiting, with potentially bleeding, which is still a minority of the cases, but it's really difficult to control when it happens. These are terribly messy cases. And so if you take a respiratory illness like SARS or influenza, you cough and you spread the illness. And it's probably a little bit more robust in terms of surviving on surfaces than Ebola. But the quantity that you shed when you're really dumping out 10 or 12 liters of diarrhea is what really makes this difficult. And so you have to have really, really good, really high quality PPE, personal protective equipment, and infection control procedures to contain that volume of virus-containing liquid. And that's why institutions going a little crazy on trying to purchase the right protective equipment is a little understandable. I've been urging that our care teams are as small as possible as opposed to really big care. You don't want everybody in the world. You want as few care providers as necessary to provide high quality treatment. But even with that, we go through you talk about what your burn rates are. How many suits, how many masks, how many pairs of gloves, what are your burn rates for personal protective equipment? And you're talking about like 100 sets of PPE per day with a team of 3 to 4 providers. And you go, well, wait a second, why is this? And even with pretty sleek, trimmed down treatment protocols, it's tough and it gets expensive very fast to do the infection control in a way that really, really narrows the potential for transmission down to like tenths of a percentile kind of range. Sorry, that was a long answer. This one is really fraught with a lot of political stuff too right now.
Can I ask here? When you talked to me earlier, you said through the Bill Gates Foundation you were being asked to test suits or evaluate them.
Yeah, the camera's gonna start moving with me right now, and I'm gonna go get some samples. So the suits themselves are fairly well standardized, and there's supply chain issues with how fast DuPont 3M can produce these things. More what we're looking at is how to make them more comfortable. And I want them to move to looking at how to make the face and head coverings more comfortable, away from N95 masks, which are distinctly really uncomfortable to wear for periods more than an hour. Sorry, it's a feedback, it sounds like. But the first things that they were working on before they got my advising were cooling suits. So let me show you some of these things, okay? Be right back. Coming back here. Okay, now first of all, this you've probably all seen pictures of, and actually you can see a video of me on the New York Times putting on the PPE. It's kind of, it'll remind you a bit of Charlie Chaplin because it's silent and it's sped up, so it all seems like very comical for me to watch. But this is a Tychem C suit without neck guard and without flap. You probably can't see this detail. There's no zipper protection. In the field, we use zipper protection, and there's seal that seals over these things. It does not have a booty. It has an opening on the feet as opposed to, and so this goes over rubber boots. In some hospitals are using suits that cover the entire shoe. This has a hood, but we didn't wear the hood because we used a separate designed hood, goggles, and 2 layers over the face. Okay, so this is hot. This is a plastic suit with sealed seams. And if you're working in temperatures upwards of 90 degrees with very high humidity, the temperature inside the suit very rapidly gets up to the 1-teens, like 115 degrees. And we were sweating off about 1 liter of sweat every within 40 minutes. So what they're looking at is different. What the Gates Foundation funded group was looking at was different military and sports hardware for cooling. And this is going to be really hard to see, but if you look at this vest, this is the vest, it has, I don't know what detail you guys can see, it looks like fingerprints of tubing.
Right, we can
all
see that.
throughout this.
Surprisingly good.
We can see it.
Okay. And here's a port that comes out the back of it. If anybody's seen a camelback, this is just like a camelback, but you put frozen water bottles in here, you put water around it, and then you've got a plug here that plugs into that vest, and a battery-powered circulating pump. Here's another version of the same, designed for sports, with a different plug-in, with a different model plug, okay? And so then you put this on over your scrubs, because you don't want it directly against your skin, and then you put the plastic suit over you, the Tycam suit, and they were seeing heart rate and respiratory rate of at least 50%. They found that people would max their heart rate and double their respiratory rate in 20 minutes of use. And I would be 110 within 20 minutes and max it like 100 and, higher than that after I work for an extended time period, and they can cut that number in half. If your resting respiratory rate is 12 to 14, the respiratory rate working in the gear was in the 20s to 30s, and they could cut that down to closer to the 21, 22 kind of range. So the trouble with this stuff is batteries, cleaning, it's pretty elaborate technology, right? And you're going into austere conditions where everything is powered by generators. And that still required a freezer to freeze the ice packs. A simpler version, and this is all, and is kind of military grade stuff, is what looks like a body armor vest, but then it has openings here that you then, let me just go get them. Stick with me here, guys. Okay. Straight out of the freezer, right? You slide these in, and then you're protected from both heat and shrapnel, I believe. I'm joking about the shrapnel, of course. But overall, lower tech, similar improvements in physiology, but with these that are more robust more robust technology, less likely to fail. There's one pack in here, and you can kind of titrate how cold you want to be by how many pockets you fill in the vest. As you work, the amount of cooling you get kind of tapers in a linear fashion with these. Not exactly linear, whereas in the vests that cycle the water constantly, you get a longer, flatter curve for the cooling properties or the loss of cooling for them. I was less worried about, I thought that the trade-off in simplicity with these vests outweighed the decline in the cooling effect. But the goal here is, and you say, well, you're just talking about caregiver comfort. But really you're not. Because if you're saying we want to be treating these patients and you want to be giving the highest quality care, but yet I can only be with the patients for an hour and 10 minutes, and the most I can go in, the most I can physically sustain in a 12-hour period is 3 trips in to see the patients, then the notion that you could improve the physiology of these and double that time, you can look at it 2 different ways. You could spend the same amount of patient care time in and cut the number of suits you're using in half. Or you could use the same number of PPE suits per day, but at least double the amount of time that you're actually caring for patients. So improving the physiology of the PPE is a big goal. I think the vests, I think that these the torso cooling measures are a stopgap. I think if we cool the head, that's where the majority of the improvements will come from. Right now, the goggles that you wear quickly become fogged and scratched. The masks are really, really uncomfortable, and everybody who's worked in this environment presumes now that they've experienced waterboarding, because it's really a very disturbing experience because partway through your treatment, and you can't predict exactly when it's, because every day's amount of exertion is different and every day's weather is slightly different. But everybody had the experience of suddenly they can't breathe. You've got so much sweat in the mask and it can't come out, and you've got so much of your own humidified air that's just condensed in there that you now can no longer, you can just barely move air back and forth. And you sit there, you got to tap somebody on the shoulder and say, "I'm leaving now. I can't continue treatment." And then you just sit there and you go, and you have to completely work to get what feels like the smallest amount of oxygen until you can get through the decon process, which is about a 4-minute process. But the whole time you're just sucking really, really hard. Like we talk about people with emphysema feeling like they're sucking through a very small, like a coffee stirrer straw. That's how much air it felt like you were getting. And once in a blue moon, people who are even experienced would just get really freaked out and scared and be like, "I gotta go! I'm gonna die!" And that was bad. That's I'm making that sound a little comical, but the decon process, the doc, and so you can't hurry through that and be safe. And that's where that's where I'm hoping that everything on the head gets improved, and then I think we can look at that as an engineering solution that improves patient care. Sorry, that was a lot right there.
Interesting.
Is the equipment, the PPE disposable, or how often do you would you switch it off?
Yeah, so most of it is gloves, the suit, the hood, and the N95 mask were disposed each time. And that's someplace between $50 and $90 each time you go in. Goggles, gumboots, and rubber apron were reused. And we were seeing survival times of about 3 to 4 weeks for the goggles before they just got too scratched up. And the gumboots, the big rubber wading boots, similarly, lower quality boots would last a month before they would get too many holes, before they develop a leak. And as soon as you got a leak, not too many holes, as soon as you saw that you had one leak, the boots got cut up and thrown away. We had to cut them because if we just threw them into the incinerator, somehow they never got incinerated and we'd see them out in the community, and we didn't want them accidentally used and people thinking they were being safe with those boots, so we had to cut them before we incinerated them.